Firstly, we'll consider posterior canal BPPV. The diagnostic and therapeutic manoeuvres are the same, both for canalolithiasis and for cupulolithiasis, although some authors recommend Simon manoeuvre for cupulo and Epley for canalolithiasis. In considering this, we will first of all describe the Dix-Hallpike diagnostic manoeuvre modified by Brandt-Daroff, then Simon's manoeuvre. Then we'll describe the manoeuvre exactly by Dixon-Hallpike, followed by the Epley's particle repositioning manoeuvre. So here we go, the Brandt-Daroff diagnostic manoeuvre. Cross your arms, turn the head to the left, 1, 2, 3. And there we are, vertigo, but also upbeating, geotropic nystagmus, and we wait until the vertigo subsides. I'm going to sit you back up. The vertigo will return, but less strongly. Let's go. We see a little downbeating nystagmus, which is always less marked than the initial nystagmus. And now we're going to repeat the manoeuvre, but this time it's as a treatment. So we turn the head again and guide it backwards. And there we are. The nystagmus slightly less strong than before because there is some habituation. And we wait for the vertigo to finish. And now I'm going to bring you back up and immediately lie you down on the other side. 1, 2, 3. And here we can see the nystagmus. It's finished and we bring you back up. You do have to be careful. Take a good hold of the patient who may grab you violently at the end of the manoeuvre as the clot of otoliths drop back onto the utricle. And now we're going to talk about an alternative particle repositioning manoeuvre known as the Epley. But we start by looking at the Dix-Hallpike manoeuvre precisely as it was first described. The head is turned to the right and we'll drop the patient backwards, just so the head is hanging. There we are. And we can see the upbeating geotropic nystagmus. Are you all right? Yes, everything is turning a little though. Everything does turn as the nystagmus appears. And as the nystagmus dies away, we wait till it finishes. To complete the manoeuvre, we sit the patient upright. And here we see a reversal of the nystagmus and possibly also a return of vertigo. Now, the Epley manoeuvre starts with the classical triggering manoeuvre of Dix-Hallpike, with the head turned to the right and then dropped backwards. There we are. The nystagmus reappears with vertigo and we wait for the symptoms to settle. Then we go on to reposition the otoliths towards the utricular end of the canal. The head, which was turned to the right, is now turned over towards the left. And so we go on. The otoliths are thought to migrate in the canal towards the utricle. Then, the third position of the Epley manoeuvre is to turn the head maximally. The whole body is turned over as if the patient was going to look at the ground. With the head turned 45 degrees towards the ground, we watch the nystagmus, and we can follow the progression of the otoliths in the posterior canal this way. We may need to wait 15 or 30 seconds for the nystagmus to entirely die away. Now the next position is to bring the patient back upwards. We begin this by asking him to lean on his left elbow and then to stay like that. And then we ask him to bring his legs down as if he was going to sit up. We come up slowly with the head bent forward. That's perfect. Hold the patient firmly though, because there can be an otolithic response and the patient